Public Health and an Affordable Care Act environment. Mayor Pittman is the president and CEO of the Public Health Institute, based in Oakland, California. He has a deep, varied, and multi-sectoral experience in local public health, research, education, and hospitals. Before joining PHI, Pittman headed the Health Research and Educational Trust, a Chicago-based affiliate of the American Hospital Association. She was president and CEO of the California Association of Public Hospitals and a director of the San Francisco Department of Public Health, which is just a little piece of the many, many things she has done around public health, healthcare, and serving underserved populations in her career. Before Mary starts to talk, I want to say one thing that she said earlier today in a group of students. We had met more informally, and someone asked her, a good question for a second-year student to say, what kind of skills or qualities do you look for in someone that you might hire? And the first answer, she said, was someone who's intellectually curious. So for those of you who are in this room, take a moment and pat yourselves on the back, because you are here on a rainy afternoon. It's not a class, it's not an exam. You are here because you are intellectually curious. And I echo that comment because I'll tell you that being intellectually curious is what public health is all about, and will keep you excited about your careers as you move further on. So with that,
thank you very much. Well, it is truly my pleasure to be here with you today. I thought she said that we had a job fair afterwards, and I was handing out job opportunities. No, just kidding. We're going to be doing a multimedia event here today, and so you're going to have to perhaps have patience with me at one point when I do a video clip, and hopefully this is all going to work out. We're doing soft tech and high tech, and that's part of what the ACA environment is all about, that we have people who are working in very low-tech environments trying to grapple with these changes, and people who are at a much higher end of the technology spectrum who are also grappling with their own challenges under the ACA. I start with this picture, and this is a walking school bus. This is from a project that we did with Community Transformation Grant funds in rural California. And that's actually something that this particular town in Madera County put together to try to get kids to walk to school instead of being driven all the time. And they didn't have sidewalks and places where the children could walk to school. They put some paths in place, and they put this together to demonstrate that it was cool and safe to walk to school. What I'm going to be doing today is telling you some elements from the ACA that you might not have talked about before. I'm not going to go through all the legal requirements and things like that, but I want to talk about how some of the emerging models of population health are opening up, and new transformative models of public health are really emerging from some of the demands of the ACA. There are many drivers in public health, but let me take you through a few. And for those of you who might not know about public health, and I'm not going to be reading my slides, so you can take a quick glance at them. PHI celebrated its 50th anniversary last year. Under my leadership, I've been the president and CEO for 7 years, and I'm the second CEO. Okay, so we had some conversations earlier about what it was like to be the second leader in an organization that has been around 50 years. We are doing much of our work on population health through a new innovation lab that we've put together, which we hope will officially launch a little later this year, and I'll talk more about that in a bit. We know that the work we do in public health we can't do alone, so most of the work that PHI does is in collaboration with other organizations, and we know that innovation is the watchword of public health these days, that if you're not constantly innovating and changing, you're probably going to be left behind. And so we'll be talking a little bit later about a few case examples of innovations that public health is taking on. In the 30 years I've been doing this work, I am both struck by the magnitude of the challenges we face, but also the amount of opportunity that exists. You can design your own job and find something meaningful to do in public health now. And I say that because as you are graduating and going out and looking for jobs, don't be limited just by what's posted on a job board. Think about your skills, think about your personal story, and think about what you want to do and where you want to have an impact. And sell that. And you'd be surprised how many times people will be able to work with you to create a job that's meaningful for both you and for them. I always like to start out with a cartoon. It's particularly meaningful today. We don't know yet what's going to happen from the court case, but you know, the ACA does represent a new day for the American health system. It's shaping incentives and disincentives and strategies for the health system, as well as opportunities for prevention. And unfortunately, you know, fear of terminal illness is what all too many people had to suffer before we had the ACA. The tenor of our dialogue has, up until recently, changed and shifted for many uninsured families. Probably many of them are on tenterhooks now, for fear of lack of access and bankruptcy. But the ACA has already shown great promise and great progress. By the end of 2014, the number and percentage of uninsured adults dropped, fewer reported difficulty paying medical bills, and for the first time, fewer adults delayed care because of cost. And we're not talking about a few people, we're talking about tens of millions of people. That is a huge impact that the ACA has already had. This is a wordle that we put together when we were celebrating our 50th anniversary at PHI last year. And we pulled it from the work that we've done over the last 50 years. And I thought it was kind of fun to look at it. And I want to do a wordle in a couple of years and see what's different in terms of the words that pop up. And I'm sure it's going to be quite different. But it's important in public health to recall all of the positive impacts that public health has had in the past. It's left its mark in so many ways, and ways that will continue to go forward under the ACA, and even if we get a hiccup for a short time. Think about immunizations for children to attend school, except in Marin County, California, I guess. That's a pretty accepted policy. But secondhand smoking laws have been driven by public health. Helmets to ride bicycles, car seats for infants, seat belts, nutrition labeling of food, violence protections, having licensing of daycare centers, and occupational safety and health laws, and so much more. The early roles of public health were obviously in relation to infectious disease, but with the demographic shifts, we now, while public health still has to continue to play an important role in infectious disease, it's the chronic disease factors that we have to concentrate on now. From cancer to teen pregnancy, we will continue to have jobs in public health, but those jobs will look different. Anti-tobacco is one of the programs that the Public Health Institute was involved with in the very early days. Another point I want to make is that things aren't static. We were the leading state in terms of providing taxation for tobacco. And now California falls in the middle of the pack. While we were out leading in those campaigns, we now have New York with $5.36 per pack of cigarettes, Rhode Island with $4.51. California is $1.88, much closer to South Carolina at $1.58, or North Carolina at $1.44. So one of the things that I realize in public health, we often claim victory, but we have to go back and look at where our victories are at that particular time and in that particular context. As we struggle in today's battle of obesity, we can go back and look at some of the successes we had in tobacco, but certainly there are a lot of other factors affecting obesity. Life expectancy for a child born in 1900 was 47.3 years, and it rose to 78.7 years in 2011. Public health interventions were the primary drivers in that increase in life expectancy. But the U.S. ranks 26 in OECD countries, and there are many reports. How many of you have seen the OECD slides about where the U.S. ranks? Okay, most of you have. I'll just quickly go through a couple of them. For the first time in history in 2011, the life expectancy across the OECD countries exceeded 80 years, an increase in 10 years since 1970. So that's real progress. And what we saw is Switzerland, Japan, and Australia, and Italy really leading the top of the OECD countries with life expectancy exceeding 80 years. And you'll hear a little bit later that while the US is 26, there are some places in this country and some interventions on a large scale that are coming up to that OECD and exceeding that OECD average. Gains in longevity and life expectancy in many of the OECD countries were a result of rising incomes and many other policies, but not uniquely that, and we'll be talking about that a little bit further. While life expectancy in the US is 1 year above, used to be 1 year above the OECD average, it's now more than 1 year below. Many of the explanations for the US lower gains relate to the ACA, highly fragmented nature of our US healthcare system and the number of people who were not able to access healthcare. We hopefully will see that part of the driver change as people are able to get access to health insurance and health coverage. But health-related behaviors such as higher caloric consumption per capita, which is driving our obesity rate, higher consumption of prescription and illegal drugs, and higher deaths from road accidents and higher homicide rates are also driving the US mortality figures. I would say the one element that often doesn't get included in those drivers for why our rates are lower are the adverse socioeconomic conditions affecting large segments of the US population, with higher rates of poverty and income inequality, and also, I believe, racism drives part of that lower rate as well. In this chart, it's showing cardiovascular disease. I think the first one is ischemic heart disease. And cardiovascular diseases are the main cause of mortality in the OECD countries and account for 33% of all deaths in 2011. They cover a range of diseases in the circulatory system, and while mortality rates have declined in nearly all of the OECD countries, with an average fall of 40% since 1990, the decline has been most remarkable in Denmark, the Netherlands, and Norway, where rates fell by 2/3 or more. We have to study what's driving that kind of rate, that kind of decline. Declining tobacco consumption is one thing that they can point to, and also they have had a rise in the economies in those countries. Improvements in medical care has also contributed to it as their medical programs have advanced. In the US, we have all-out campaigns supported by the American Heart Association, by various philanthropies such as the Robert Wood Johnson Foundation, the CDC, and many local public health agencies and nonprofits and corporate entities trying to bring down heart disease in the United States and reducing the burden of disability and the overall burden to the community. We're hoping that the ACA will provide incentive and new models for public health and healthcare to work together to address health outcomes in the US, whether it's heart disease, diabetes, or obesity. But what will it take for us to really see higher life expectancy in this country? Well, again, going back to some OECD slides, higher national income as measured by GDP per capita is generally associated with higher life expectancy at birth, although this relationship is less pronounced at the highest levels of national income. There are some notable exceptions with Japan and Italy, and in the United States and Russia having higher incomes but lower than expected life expectancies would make one question whether GDP and income alone is a major contributor. In the US, we have the highest spending per capita, but yet we don't have the life expectancy that one would expect. I'm going to try my video clip now, which is talking about, there we go.
No.
Here, I'll let you. All right. This is from Unnatural Causes.
Several years ago, two physicians in Chicago set out to solve a mystery.
Sorry.
African American women have babies that are born too small. at twice the rate of white Americans. Richard David and James Collins are neonatologists, pediatricians who specialize in the care of infants who come into the world too early or dangerously underweight, and often both. Like virtually everyone in their field, they were troubled by the striking racial differences in rates of premature and low birth weight babies. What could account for the differences?
I originally thought that the disparity in premature delivery was really driven by socioeconomic differences between African Americans and whites. It's well known that African Americans have a lower collectively socioeconomic status than whites, are less likely to receive college education than whites. So I thought once you corrected for that, that the gap would go away.
But Collins and David discovered the gap didn't go away.
We were very surprised to find that the gap actually widened as education and socioeconomic status improved. And then began to look at it from a bigger perspective, a broader perspective, and really started to realize, well, maybe it's something about lifelong minority status, which is the driving factor here.
There's something about growing up as a black female in the United States that's not good for your childbearing health. I don't know how else to summarize it.
So the two neonatologists began to explore whether being a member of a particular minority group might affect pregnancy outcomes, and they came up with a controversial hypothesis. What's behind the low birth weight and premature birth for African American babies is the unequal treatment of African Americans in American society. In other words, racism is taking a heavy toll on African American children even before they leave their mother's wombs. It's an idea that's slowly gaining acceptance.
We're in the midst of a paradigm shift. 15 years ago, racism as a risk factor was almost never heard of in a scientific paper, whereas now it's much more a possibility.
The story of
That's part of, that's part of what we were saying in terms of intellectual curiosity, not accepting the status quo answers for why something happened. I love that series. If you haven't seen Unnatural Causes, it really does make you think and question. This is a good visualization of what happens when the external environment becomes internal. And perception of stress is influenced by one's experience, your genetics, and your behavior. But when the brain perceives and experiences stressful, there are physiologic and behavioral responses that are initiated that lead to allostasis and adaptation. The body wants to get to a state of balance. Over time, this allostatic load can accumulate, and overexposure to neural, endocrine, and immune stress mediators can have adverse effects on various organ systems, leading to disease. It's an explanation for adverse life events and how they affect the somatic manifestations creates one of the strongest cases, I believe, for addressing the social determinants of health as part of our everyday explanation of what's going on. And I'm sure many of you have seen this model. This is one that the Robert Wood Johnson Foundation has put out for the county health rankings. I think it was a major game shifter in getting local public health departments to start to think differently about how well they were doing as a local community in terms of health outcomes. Now granted, this is done at a county level, so it masks a lot of the subpopulation differences, but at least it's a starter to get the conversation going. It's clear that what our physical environment looks like and the ability to connect health with the built environment as we navigate our daily lives is important and contributes to different levels of stress and disease. The Urban Land Institute released a toolkit called Building Healthy Places, And it's a really interesting toolkit to look at because it details strategies for enhancing health in the built environment, offers evidence that supports those strategies for enhancing health outcomes, and it focuses on real estate, incorporating practical ways that healthy environment can coincide with the business of the built environment. As an example that they give in terms of some interventions, in North Carolina, where 1 in 10 residents has diabetes and 1 in 3 have hypertension, only 13% live within a quarter mile or a half mile of a park. So opportunities for physical activity in a park-like setting can be hard to find. And in this particular study, many of the people didn't have a sidewalk to even go out and walk on sidewalks. So a solution was developed, shared between the local health department and the faith community to offer free and open locations for physical activity and other forms of socialization. Nutrition, this is a nice little amalgamation of what children see every day in terms of marketing. It's important for children's development that they have healthy nutrition for their brain's function and for their long-term health. Eating fruit during adolescence, for example, in place of foods that are high in fat and sugar and salt can protect against long-term health problems such as diabetes and obesity. It's also been shown to be helpful in terms of their learning process, their readiness for learning. There's no doubt we have an obesity epidemic, but if these are the predominant or only messages that we're giving to children and adolescents, how can we expect them to adopt healthy behaviors? The social environment is also critical for us to consider. As we just saw, the cumulative effect of one's social environment and relationships are complex and changing and have an impact on us whether one perceives that impact at the time or not. And even whether one perceives themselves as healthy or not. Whether one has a social network and whether you define yourself as living in a healthy community is often highly correlated with whether or not you yourself perceive yourself as being healthy. We've already shown that GDP does not perfectly correlate with on a country level with longevity, and yet it can be one of the best predictors at the individual level for life expectancy, along with education, which is closely related. So I've identified here a subset of ACA-related terms and factors that I think are contributing to new models of public health. The triple aim, the IHI, the Institute for Healthcare Improvement, established this framework a number of years ago to describe an approach for optimizing health system performance. It was their belief that new designs have to be developed that simultaneously pursue 3 dimensions, which we call the triple aim. The first is improving the patient experience of care, including quality and satisfaction. And think of someone who's uninsured, who has to go and wait for a long time in a clinic or in a hospital ED. Their satisfaction level, their patient experience is pretty poor. So one of the reasons that we're hoping that the ACA is going to help contribute to the triple aim is certainly in the patient experience. The second is reducing the per capita costs of healthcare. For many people, it's just not sustainable to be paying what they're paying for insurance premiums or out-of-pocket costs. And I showed you that earlier slide. ACA is having a positive impact on the out-of-pocket costs that people are having to spend. And the third is improving the health of populations. Now, there's a lot of discrepancy in what people mean when they talk about population health. The definition that I like to use is one that has come from the IOM Roundtable on Population Health Improvement, and I sit on that roundtable. It derives from Dave Kindig's original definition of population health, and it is the health outcomes of a group of individuals, including the distribution of such outcomes within a group, and while part of the definition of itself, it is also understood that population health outcomes are the product of multiple determinants of health, including medical care, public health, genetics, behaviors, social factors, and environmental factors. I'll be talking a little bit later about community benefit requirements and public health accreditation. I think those are major drivers for how we are seeing public health and healthcare work together. and are also providing some incentives for population health to be actually implemented on the ground. The Prevention Fund and CMMI, for the first time ever under ACA, we had funds set aside for prevention. This was a really big deal. Although the funds were raided several times in the first couple of years, the federal government does have a source of funding that can be allocated for us to get some of the evidence base and to be able to start to describe population health with very concrete metrics and examples. And CMMI is the bridge funding for healthcare and population health to be looking at other innovations. I would say, though, as someone who's looking at these things, the other innovations, some of the disruptive innovations coming from technologies and coming from companies like CVS deciding that they're not going to sell tobacco products anymore and going into health screening and viewing themselves as a public health company, are going to really help shape who we count in the community as part of the public health system. In this model, it's showing that community benefit and health reform are creating some new incentives as you move from the current payment models over to global budgeting, which is kind of the nirvana for where we're moving toward value in healthcare. As we move towards population health approaches with financial incentives to keep people healthy, we're going to be seeing providers taking on more risk. And that challenge is going to be, how do you bridge that time between providers taking on risk and getting the models in place that will allow us to keep people healthier? And then the second question, I think, is how do you shift the dollars that are embedded inside the healthcare system and inside the insurance system into the population health strategies? Well, one of those ways, I think, is through community benefit programs. After the ACA, there was an interest in seeing the IRS regulations, and Section 9007 was implemented, and numerous tools were put in place to give community groups more access to community benefit planning, and also to learn how to advocate for population health strategies for unmet community health needs, using some of the community benefit dollars from hospitals. Some of the final regulations that I've listed up here don't sound very earth-shattering, but they're actually pretty major. First, a community health needs assessment has to be done every 3 years by a public hospital. It has to be made widely available and publicly available. And they have to put an implementation strategy in place that follows what the needs identified out of the health assessment are. They have to take into account persons who represent the broad interests of the community and persons with special knowledge or expertise in public health. Public health is actually named in the regulations as being required to be part of the process. There are also requirements to evaluate the impact that the implementation of prior assessments have on the implementation. So there's a feedback loop that has to be put in place. And I see public health as playing a role in helping to monitor that feedback loop actually results in action and investments going where they're supposed to be. And there are some protections for non-English speaking populations. So Schedule H is where hospitals have to report the various elements of what they're doing. I want to focus on Part 3, community building activities, because this is the area where there's the greatest opportunity for public health to actively engage in the process, in addition to the needs assessment area. And in the community building area, these are some of the activities that are allowable as a result of a report that was actually done by Kevin Barnett, who's at the Public Health Institute in 1997, that focused on what are the root causes of health problems in local communities that could be addressed by community building activities from hospitals. So you see that coalition building and community health advocacy and physical improvements to housing and streetlights and social support for childcare are now allowable in the IRS. And their prior assessment that community building was not allowable, that only charity care really was allowable for your community benefit, was really based on not having that understanding of what the linkage between having safe streets, nutritious foods, safe housing contributed to the overall community benefit. The revised instructions say that those community building efforts can be counted as part of a hospital's community benefit. And it also says that if a public agency requests something to be put in, even if it did not show as the top of the community assessment that the hospital did, but perhaps it showed as a top priority from the local health department's community assessment, it can be incorporated in. I'm focusing on this and giving you some detail because the increased transparency that's required from hospitals for community benefit is really a game changer. As you take a look at hospitals in some communities as the major employer and as a major anchor institution, and you look at the level of funding that they have to put into community benefit, it is a way to begin to drive the system upstream. And these are some of the, there's huge variation when we've studied what goes into community benefit needs assessments and plans. There's huge variation. And so they put this transparency in place so that local communities can begin to have some accountability from where the resources are being spent. And again, I think public health has a major role to play. This is a model that the CDC has developed, and they've been actively involved in finding ways to bridge the gap between healthcare, public health, and community accountability. The slide shows ways that shared ownership can be promulgated through the assessment, planning, and implementation by different points along the way where strong cross-sector collaboration can occur. I was asked earlier, what are some of the skills that you need for the future? I think GIS mapping and having a good understanding of data is absolutely critical. Big data is what the future of public health is going to be about, and we will be relying on that as one of the ways that we are able to both project diseases and hotspots in community, as well as evaluate our implementation and interventions. The emerging technologies have reduced the cost of managing these large data sets, and GIS mapping is a great way to be able to share publicly with a community so that they can easily understand without having to come to Drexel and get a degree in epidemiology. We've worked with the CDC on a public data platform. It's www.chna.org. It was launched in 2012, free to users. So this is free. If you're doing work, you might want to go on and look at it. You can pick any geographic area in the United States. It has 8,000 publicly available databases, and you can overlay and pick different indicators. It will map those indicators for you. It cuts down on your time if you're doing a project. I urge you to look at how you might be able to use those maps to enhance whatever your research is showing. This next slide, sorry, it's a little small to be able to see some of the maps, but it also has a reporting tool. And so you can download the data tables that went behind the indicators, and it will populate a reporting tool for you as well. We thought it was important. We use this with community transformation grantees in rural areas in California. We train them how to use this tool, and they used it very effectively because many small health departments don't have the resources to have someone who's trained in GIS mapping. They may have a part-time epidemiologist in some of these very small counties. So we thought it was important to make that tool publicly available. Again, this is a roadmap that we developed with the list of collaborators on the side, including the CDC, to try to understand how data and evidence-driven population health solutions can be mapped out. And you can intervene at various points around this map, but I think the interesting thing to me is that people are putting these kinds of models together, and we tried to overlay a number of the models. You're starting to see some consistency in the models in terms of how you use data, how you engage the community, how you have a feedback loop. So where are we in healthcare? Neil Halfon, who's at the UCLA, published a paper on health delivery system transformation, and I'd argue we're between 1.0 and 2.0 in transformation in healthcare. The payment and delivery systems are pushing us towards more patient-centered medical homes and ACOs and bundled payments, and CMS is definitely pushing the envelope through some of the funding with CMMI. And in January, the Secretary of HHS said that the goal will be to have 85% of all Medicare fee-for-service payments tied to quality or value by 2016 and 90% by 2018. That's going to be a game changer. When you start to link incentives to payment models, you see change happen really quickly. CMS laid out their plan in the New England Journal of Medicine in January on how they intend to move beyond a traditional payer to improve population health, and I encourage you to take a look at that. New community benefit requirements are fitting into these models. The overarching theme is as healthcare incentives are changing, and they'll be based on value, not on volume, they'll be more interested in producing health, in moving upstream and moving into the population health arena. So, as we're moving into population health, we have to come to terms with health inequities. Unhealthy housing, as you heard on that film strip, unsafe neighborhoods, all of the kinds of environmental assaults that make it difficult for people to have a healthy lifestyle is contributing to chronic stress and chronic disease. So where do we have some opportunities? Well, first of all, beyond the check the box approach, to me means that we're going to engage in a really meaningful process. That is no longer checking the box, we have this person and that person in this group and that group sitting at the table, but we're actually listening and we're including their feedback into the process. Both the community health needs assessments for hospitals and hospital community benefit and the public health accreditation use similar models where they establish a baseline data set, they determine priorities and programs, they do some testing, they have some evaluation, and then they feed the loop back again. But I think it's really the alignment of the programs and services with the engagement of the community that is the game changer on that. So we've done some studies taking a look at different players across the community. There are many parts of the health system, whether it's somebody who's doing a health impact assessment, a local health department doing a community health needs assessment for accreditation, or doing community health improvement plans for a funded program, hospitals doing their community benefit, or if you move over towards the right, financial institutions doing community redevelopment assessments. They all define community for their own specific needs, but they all have a slightly different definition of community. The ideal would be to have more synergy and more linkage across these different actors who are doing some similar but yet different activities around defining community and then creating interventions. I put this next slide up. Same group of actors, they all have different core expectations for what the process of community engagement and community assessment should be coming out with. For a health impact assessment, it's to determine whether a policy has had the kind of impact on health that they expected. And for the financial institutions, it's whether or not they're meeting the credit needs of the communities in which they operate. So we tried to then take a look at the same actors doing that work. Where are there opportunities for alignment? There have to be broad databases, and there can be a sharing of data across these different groups. So first of all, if you could start with a common database. Incorporating the multiple determinants of health across all of these and having some common form of reference and common vision of how the social determinants affect health is another thing. And all of the infrastructure that's needed to be able to do these processes, if you could come up with a backbone organization that could do some of the linking across these various efforts, that could also be very helpful. And for the CRA, it provides a good opportunity. The alignment provides an opportunity to expand beyond the traditional and historic areas of investment to those that can have a broader health impact. So we've done some research taking a look at some of these programs, and particularly looking at the hospital community benefits. In one study, we looked at the priority setting that came in 10 states with 51 hospitals, and it was a total of 45 community health needs assessments and 27 implementation strategies that we reviewed. In all 44 hospitals, they defined the community as their service area, okay, as their service area. This particular study came out and was influential in the final adjustment of the requirements for community benefits, because it also showed that where there was a geographic concentration of disparities and poverty, many of the hospitals cut out that area from their service area. And so then the requirement was put in the final regulation saying that you could not do that, that was not allowed. When you take a look at priority setting, they did a better job in terms of creating criteria with sufficient specificity to be able to inform their decision making. But if you, I'm gonna skip this slide. If you take a look at engagement, what you see is that engagement after the initial needs assessment phase falls off, with the community being much less engaged or having much less opportunity to engage in the priority setting and implementation part of the strategy. So we certainly have some work to do to see that the full process, that circle that I showed before, is followed with the community being involved all the way along. Place matters. In California, the California Endowment has had a statewide campaign in every county showing the disparities that exist between one zip code and another. In Alameda County, you've got an 18-year life discrepancy between a high-income zip code and a low-income zip code. We think that this is a really important discrepancy and disparity to be able to have people, you can understand that at a very visceral level, that, you know, why should my life expectancy be 18 years longer when you hold constant other things in a person's life? Well, some of the health systems have gone beyond just doing a community health needs assessment and are trying to figure out how they take into account the social and environmental determinants of health. What I've put up here is a community needs index that was developed by Dignity Health, which was formerly Catholic Healthcare West. They developed this in conjunction with Seleucient, which is now part of Thomson Reuters. And this tool uses demographic metrics such as poverty rate, unemployment, home ownership, race, ethnicity, insurance coverage, high school non-completion rate to create their own GIS tool and a composite metric that serves as a proxy for health disparities. They mapped this to all of their facilities, and they overlaid these maps on the other community health needs assessment maps that they had to identify where they were going to put their resources to intervene so that they could not only hit the high need populations where the community needs were high, but as a result of that targeting, they found that the rates of preventable emergency department and inpatient utilization in the high negative ranking areas were over twice as high as other communities. So as part of their drive to be able to reduce their costs, to have better patient experiences, to move towards the triple aim, they are now targeting those high need areas for their community benefit and for their mission priorities. In this slide, I'm just trying to show the kind of transformations we need to move from the medical model of population health to a place-based model of population health. There are a lot of groups who are committing to more transparency and an evidence-informed practice and quality improvement. So, for example, if you take a look at moving from assessing patient health status to assessing patient health status along with their social and environmental risk factors. There are some health systems that are now changing what their intake assessment includes. Questions that they ask about, do you feel safe in your neighborhood? Do you have access to healthy and nutritious foods within a certain distance from your home? Building internal population health competencies within the health system is another thing that we are seeing hospitals take on. So just another model that is addressing the social determinants of health, looking at how you can define what the core content areas and then mapping it to the indicators that need to be monitored and the outcomes. This is the kind of work that I see local innovative public health departments doing now in conjunction with health systems. This is a little different than the kind of work that you would have seen a local health department doing, 15 years ago. But I think that it's a positive move towards really a much broader definition of the role of population health in the local health department. So money's important. How we're going to pay for population health still remains a bit of a fuzziness until more of the health systems are in that value environment. Excuse me. And while we may develop the infrastructure and tools for population health in a little more robust manner, they're not there yet. Some of the research that I hope some of you are taking up are the analytic models for projecting long-term impacts, looking at the business case evidence, and looking at some of the ways that the linkage between how health care is paid and what the outcome is in the community. One of the risks I think we have is that we're going to come up with a perfect payment model for health care and not take into account meaningful population health. I know CMMI put out a number of calls for innovation. Very few actually address the real upstream determinants of health. The other challenge and risk is that savings are going to be realized within the health care system, but they're never going to be reallocated to the upstream activities. So a source of advocacy is needed. I put this up here just to say there's a lot going on, but there are a lot of national initiatives. Stakeholder health comes predominantly from 40 health systems that said we have to learn more about population health, get more actively involved, and bring more stakeholders into our process. They coordinate with the Health and Human Service Office of Faith-Based and Neighborhood Partnerships, and they are beginning to see a change in how they deliver their care, and particularly how they are reshaping their primary care as a result of that collaboration. The 100 Million Lives campaign, this is a new campaign being launched out of the Institute for Healthcare Improvement, just started in October of 2014. It's a distributed leadership model where IHI is serving as a backbone with hubs all around the country. You should check, there'll be one here in Philadelphia. It's moving from a health-centric to a broader systems change approach, emphasizing shared learning and a social movement towards population health. The National Collaboration for Health Equity and Place Matters Initiative, similar lines. I won't go through, you might want to take a look at some of those others. Rethink Health has an actual simulation model to show if you invest upstream what the impact will be in the overall health of the population, and if you decide to invest in certain technologies or certain specialties, what the long-term impact will be. It's not a simplistic model. It's not even always intuitive. It's a very interesting model to test out. So if you have the possibility to perhaps someone have someone from Rethink Health come and do a day. I think it would be interesting. I mentioned the Population Health Innovation Lab. We're working with health systems and insurers, local providers, local clinics to try some innovative things and see if we can pull some of the evidence and data together, and most importantly, to have a learning collaborative across those various nodes of innovation. So there is an imperative for convergence between health and community development. And I bring this to you because I think this is one of those real disruptive innovations. What we're seeing, there was a report that was put out by the Robert Wood Johnson Foundation along with the Federal Reserve Bank in San Francisco. And they had a number of essays. And now there are a couple of innovative test sites around the country that are taking a look at how can you bring public health, healthcare, and the banks together to focus their investments in ways that can have shared metrics, shared data, and ID neighborhoods, census tracts, or zip codes with concentrated health, social, and economic inequities, and then focus the interventions and investments. So you're bringing hospital community benefit investments, you're bringing the bank investments, and you're also bringing the local health department. This is another model that's dealing with the same crossover between communities and the banks investing in improving and catalyzing collaboration across health and community development sectors. The three focus areas for this one are in data and measurement, policy change, and financial innovation. The impetus for all this work from the banks is the Community Reinvestment Act, and I think it's important just to note the genesis of this program and where it is going now. This came from redlining that existed by the banks in the mid-'80s, and they are required now to invest in geographic areas that meet the CRA criteria of an equity investment, where their members come from, who deposit in their banks, and there are billions of dollars a year. So if we want to look at where some of the future funding for public health initiatives are going to come from, when you look at the community benefit funds, it's a lot more than a lot of local health departments have, but when you look at what the banks have for CRA, it's many times over those sources of funds. So some of the potential areas that we're seeing investments in are housing redevelopment, community health clinics being invested in, grocery stores in food deserts are being launched through this. You're seeing infrastructure for parks and a whole variety of things. And it's helping to create collective impact. You're seeing the various sectors, those that I listed on that chart earlier, begin to meet the 5 conditions for collective impact. They're creating a common agenda, a shared measurement system. They're finding mutually reinforcing ways to take on activities together, continuous and transparent communication, and having a backbone support organization. This is absolutely critical because collaboration doesn't get sustained unless it's someone's responsibility to sustain it. This was a model that was put together in where multiple groups in one geographic area came together to focus on obesity. And you see the little models for the different sectors, their shared metrics, and they had a backbone entity responsible for tracking both the investments and the outcomes along each of those metrics. I see public health as playing a kind of strategic role between the community development and hospitals. And in fact, that's the case in a lot of the demonstration sites. That's what we're seeing, that the public health department is in fact the neutral convener and bringing those pieces together. I want to give you 2 last quick examples where public health departments have taken the lead role with great success. Kings County in Seattle focused on obesity prevention and used the STEPS place-based model. Their goals were to reduce the impact of chronic disease and prevent and prevent and control asthma, diabetes, and obesity. They wanted a comprehensive approach. The intent for the STEPS program was to link improved service delivery and integrated community-based organizations. Public Health was the lead organization, and they had more than 75 other organizations, including all of the healthcare sector major players at the table. They targeted a high-need geographic area with 350,000 people with a large race, ethnicity, diversity, and 30% of the population was below 200% of the federal poverty level. As a result of their interventions, 45% of the people were enrolled in a case management program with a primary care provider. They had 40% fewer ED visits, 38% improvement in diabetic control. They had a 41% increase in days with no asthma symptoms by the people who were in this area. They saw a reduction in television time and an increase in physical activity by the youth. It is quite an amazing outcome that they saw from this effort. A second approach, and one that I think is even more comprehensive, is this one from San Diego, where they have 10 indicators, 5 areas of influence, 4 strategies, 3 components, and 1 integrated vision. Live Well San Diego is a model that's bringing all elements of their local government, business, and health sector together. They're changing the culture within county government, but they're building better systems in the healthcare, social services. They're linking with the criminal justice system, and they're really trying to take a look at where are their gaps, where people fall through the cracks. So they're bringing more sectors together than just about any other model that I've seen. They're early, they say they're very early in their process. They've been working on the plan and doing this work since 1978. They now project the life expectancy for a baby born in San Diego in 2014 is expected to be 81.6 years, approximately 4 years longer than the national average we saw on those earlier charts, and rivaling the top 3 OECD countries. As part of the efforts to create positive outcomes for their Seniors in Care Transitions Partnership, they've been able, by working with public health and with local lay leaders, to prevent hospitalization and readmissions within the first year for 500 seniors, with $2.7 million in Medicare savings, some of which is going back into the upstream care transitions program. Taking a page from the Robert Wood Johnson Foundation, what we're doing is talking about building a culture of health. And I put that report that was put out by the Health Research and Educational Trust, one of the places I formerly worked at, because what's noteworthy are the hospitals are talking about strategies for creating a culture of health. This is a time when some unusual partnerships can be made, where you can see some things change and happen that we couldn't have imagined a number of years ago. In summary, I think everyone has a stake and a role to play. Don't underestimate the power of partnerships and the resources and funding mechanisms that can be brought to bear on what were once called intractable social problems. They're no longer intractable social problems. They are things that we have to focus on, we have to deal with, and public health needs to be leading the charge. Community development, with its focus on poverty alleviation and revitalizing local income communities, is a natural ally in addressing some of these upstream determinants, and they are getting on the bandwagon. Addressing inequality and disparities are going to drive us to take seriously the integration of the social determinants of health in all the work we do. So what's next for public health? I put this up, but this is another talk. I think we're facing one of the greatest threats from climate change, and public health is just starting to take notice of it. We did a study for the Kresge Foundation, and we laid out a framework for where public health can play a role, and it's combining the challenges of social inequities and social vulnerability with climate change. And if you go on the PHI website, you can download that report. Thank you so much for letting me address you today. little past my time. I don't know if there's any chance for any questions.
Yeah, I think we're time for questions.
Okay.
I think you have a little bit of time. Folks have to go, you have to go, but if you want to stick around and ask some questions. My two colleagues in the front row, Jonathan?
Yeah, thank you so much for your talk. I really enjoyed it. So population health is obviously a very prominent theme. So as a doctor of public health who works at the Public Health Institute, do you see population health as kind of just a new term for public health, or is this kind of the birth of a new discipline? And if the latter, what is the place for public health? So public health departments, doctors of public health,
It's a very good question, and I at first was saying public health has always done population health, so what's new? I think the what's new is the fact that we are really starting to bridge the clinical care side with the community-based and the public health side. I think that is a real game changer. For years, people have said we have to bring those sectors closer together. I think this model of population health, in some ways, it gave a neutral territory not owned by public health. So I think it was more appealing for people to come to the table, but it's certainly using many of the tools and many of the approaches that public health always has. One of the reasons why I think public health is a natural leader in this area.
Jenny?
Yes, so you led your description about the Public Health Institute as using evidence-based practices. And it seems like one of the important things as the ACA gets implemented is to do a rigorous evaluation where we really do have treatment and controls and sort of be able to separate out the real effects. Could you talk a little bit about those and some of the projects that you mentioned, or how the PHI is approaching that problem?
For those of you who couldn't hear a question, it was how is PHI that likes to use evidence-based practices for policies and programs, taking a look at the ACA and trying to really gather the evidence. We have some people who are monitoring, using, big data analyses, trying to monitor a set of indicators across California very early, and taking a look at people who were uninsured before and who are insured now, and taking a look at what the changes are in those particular counties, because you can't just look at insurance, you have to look at the whole variety of changes that are going on, because it's multifactorial. It's early on. I can't tell you what the results are, but there quite honestly hasn't been a whole lot of money to do the evaluation. So this is being done by someone who has access to the data, has a passion about it, and a very tiny amount of money. But I think that that's an important element of what we need, is more research that's actually looking at what the interventions are going to yield in terms of not just individual health, but overall population health. Thanks.
Hi, that was a very thorough talk. I learned a lot. It seems like nonprofit hospitals are incentivized to engage in population-based health through the IRS incentives. Are private hospitals incentivized in any way, and in what way are they?
Because the IRS is based on, taxation, and private hospitals actually pay taxes, and in fact there are some nonprofit hospitals that pay taxes as well. They choose to pay taxes. The only incentive, I think, is the community suasion, and a lot of communities where the hospitals have gotten together to do a community health needs assessment. Good example is in Georgia. The for-profit hospital joined in that coalition of hospitals to do that work. They didn't have to, but they chose to do it to be part of the community. And so I think it's really community pressure for them to join in, but they're not mandated.
So you talked a lot about chronic stress and social inclusion and things like that as being a part of health. And I'm sort of interested to hear your take on where mental health and physical health care can be integrated, and how all of that can play a role in creating, better population health.
Really good question. I think mental health is one of the elements that has been left out for so long, and now that we're supposed to have parity, at least in name, we're supposed to have parity. I think it's going to take advocacy and it's going to take research to show where the disparities exist. There are so many studies that show the impact that and the comorbidities of depression and other mental health issues and how it increases cost and slows someone's ability to recover from other physical health problems that you would think it's a no-brainer. We need to be addressing it. But there has been the stigma and the lack of resources going into that integration. I do think it's one of the next frontiers.
I was wondering if you could speak a little more to what you were talking about with the evidence for the business case for population health, just kind of some of that evidence and what that meant.
There are a few studies that show when investing in prevention pays off, but very few, and I think there needs to be more rigorous studies showing if you invest in, for example, if you invest in having good prenatal screening and good prenatal care, what's the payoff? Now that's kind of an easy one because you can see it in 9 months. Some of the harder ones, we've shown the return on investment for asthma. Again, that's something that's short term. But what about preventing cardiovascular disease and starting when kids, are very young? I think the Kellogg Foundation, with their focus on 0 to 3, and now Robert Wood Johnson Foundation in their childhood obesity efforts are going to focus on 0 to 5, are understanding that we have to begin to do some longitudinal, long-term metrics around what the impact is. There are some studies that have followed kids from kindergarten through high school where they have implemented physical activity programs that, where the kids are actually active, and they see lower BMI, they see better behavior in the schools, and they see better test outcomes, So those are the kinds of things that I think we have to be more rigorous. And then we have to compile them in a way so that they're readily accessible and they're used for policy decisions, which is that next step that's so critical.
Two last questions. And then Dr. Van Alden minutes, so also Stephen.
Thanks, Dr. Pittman. So earlier you were talking about how innovation has now become the buzzword in public health. I was wondering if you could speak to innovation in the feedback loop portion of the model, specific to incorporating cultural competencies and linguistic challenges in different regions of our country, since our demographic has now changed.
Are you asking what are some innovations that have been included? Well, I certainly think there's one, and actually when I was at the Health Research and Educational Trust, Ramana Hasnain-Winia was my vice president for research. She's now at Pcori, heading up their disparities research. And we were trying to take a look at what happens when someone enters into a healthcare system, because disparities had been ascribed to being lack of access. And we said, but there are disparities once people get in, whether they have access or not. So what's contributing to that? It doesn't sound like much of an innovation, but I find innovation runs an entire continuum. A lot of people think high tech, but an innovation can be as simple as what we came up with, which was finding that when data was used across different hospital systems, they collected data on race, ethnicity, language preference, cultural and religious beliefs in very different ways. And so that data was not comparable, and even if they collected it at all. So we spent a long time really understanding, how do you ask that information? How do you get people to tell you, what their preferences are? It's usually a clerk who's taking that information on intake. How do you make them feel comfortable and not feel bogged down or embarrassed? So we spent a couple of years, we came up with a protocol, tested it, found a way that could be put in place, and then got a common data set in terms of giving people also flexibility so that you didn't fit into one of 4 or 5 categories, so that, you know, mixed race, different options were available. And so that then was uniformly applied by the federal government. It was uniformly applied by Joint Commission. You want to get a hospital's attention, you make it a Joint Commission requirement. And so then we had the data where we could begin to do the analysis and see, you know, what are some of the causes and what works well. So that was an innovation. Sometimes innovation is very low tech. It's on how do you even set up the way people, when they come into whatever kind of program you have, what first greets them? Are there barriers, or is it welcoming? Can somebody walk in and not be of the same language, color, belief system, and feel that they can get the help that they need? And what do you put in place to make that happen? I think cultural competency and language access and health literacy are all really, really important, and I don't think we have a full implementation across our different programs by any means.
Do you have time?
Yeah.
So that was a great talk. Thank you very much. I think what you said about the potential for new partnerships is really important. At the same time, sometimes it makes me a little bit ambivalent that we are, you know, moving in the direction of making hospitals responsible for the health of their communities. And that, in a way, goes a little bit against, I mean, if we take seriously the fact that health is driven by all these other factors, which often don't have anything to do with healthcare. So it's a little naive to think that the hospitals are really going to be able to do something, even through the community activities, which are, you know, very good that they're doing them, but really. And so it worries me a little bit in public health that we might be falling into a little bit of a trap of re-medicalizing things when we really should be doing exactly the opposite.
I would agree with you if we allowed the issues to become medicalized. I see the partnership as the hospital is trying to keep people healthier, them reaching out so that they are supporting the work that's going on in the community, not ascribing all the responsibility for it, because they're not prepared. That's why I think public health and a lot of the community social services and community-based organizations are absolutely essential to be partners there. One, they, as we see the shift towards population health be incorporated into what hospitals do, I think you're going to see changes in how clinicians think about their patients. So, for example, I think it's going to change the care paradigm. So if you have someone coming in and you're not asking them the questions about, do you have a place where you can go walk, and you're telling them lose weight, I think it's changing the mindset inside the hospital as well as how they partner outside. I don't think that the hospital should be solely responsible by any means for creating a healthier community, but I think they have to be part of the equation. And there's also a fallacy that a lot of folks go to the hospital and just want to pick their pockets and have them pay for what's going on. I don't think that that's going to work either.
Thank you.
Well, thank you. Thank you all for coming.
I jammed a lot in a short period of time there.